Today's lecture is about orthodontic indices. So, why do we need orthodontic index or orthodontic indices? The first reason is to provide treatment or not. So let's look at this photograph. This patient obviously needs treatment, while this patient is in a mild need for treatment. So yeah, we definitely have to provide treatment for this one as a priority. But then a case came like this. So which one has more priority? And this is very important when we are talking about a health system in which the government is providing the treatment. We're not talking about the private sector, because in the private sector everybody is going to get treatment. What I'm talking about, if for example in the UK, the national health system, the NHS, is the one that is providing treatment. So now we need to tell, out of these three, in an objective way, which one is in more priority for treatment of these three photographs. For that reason, we need indexes to help us to decide that, to provide the treatment, which patient needs treatment. So before going into the example of the indices, what these indices should have? They should be reliable and reproducible. So if you repeat this measurement, it should be repeated again. It should be valid, which means if it should measure what it meant to measure. It's really measure which, when a score is high, it means that this patient is in need of a treatment. And when the score is low, that this patient really doesn't need for treatment. It should be objective, not subjective in the method of the assessment. Should be simple to apply. You don't need an index that it takes you hours to apply it, or half an hour in a busy clinic. And it should be definitely acceptable by the patients and by the public and the professionals. So the first one that we need to study is the index of orthodontic treatment need, which is the IOTN. It is the most commonly used and recognized index in the UK. It's based basically on the Swedish National Board for Welfare Index, and it's modified a little bit to get the index of orthodontic treatment need. It shows to be reproducible, and we're going to come back later to the advantages and disadvantages of the IOTN, but it's showed to be a reproducible one. And it's divided into two components, the dental health component and the aesthetic component. So we'll start about the dental health component. The dental health component is divided into 5 hierarchical scales, starting from grade number 1 goes to grade number 5. With grade number 1, no need for treatment. Grade number 2, little. 3 is a borderline, while grade 4 is need for treatment, and 5 if a great need for treatment. So patient is graded according to the worst occlusal features, and we can't add up. So for example, the patient has a increased overjet and impacted canine. We record only the worst one. We don't add these two together. That's how the IOTN work. Then the 5 categories, these ones are further subdivided using letters to explain this kind of malocclusion, and we're gonna see now how to do that. So the sequence that you should follow is called MOCD, which is missing teeth, overjet, crossbite, displacement of contact point, and the last one is overbite. When you evaluate a case, the priority is always for the missing teeth, then the overjet, then the crossbite, then the displacement, and then the overbite in the assessment. And so if the patient scored in the missing teeth, then that's it. It will get the score because that's the highest one. So you go from the top of the list down. In order to do the IOTN, you need something, we call it the transparent IOTN ruler. So if you look at this one, we're going to explain this later as well. This part here is for the positive overjet, while this part here is for the negative overjet, and this part here is for the displacement of the contact point and the open bite, while the one here is kind of different malocclusion written. We're going to come to this later as well. Just keep in mind that this 2 here belong to the negative overjet here. It does not belong to the positive overjet, but because the space is very small, they write the 2 here. So we'll start with the first one in our sequence, missing teeth, which include impacted, impeded eruption, and hypodontia. So if you have an impacted tooth or impeded eruption, that goes to 5 immediately. That's a great need of treatment, and you get the letter I. Well, if it's hypodontia, it's either 5H or 4H, and we're going to see how is that distinguished. So The tooth is called impacted or impeded with the eruption if the tooth failed to erupt due to obstruction, dilaceration, or lack of space. That goes to a 5i. So for example, if you look at the central incisor here, you can see that the right central is erupted, the left central incisor has not erupted yet, while the lateral is there. So now we can say that there is a change in the sequence of eruption. So that means that there is something wrong with this central incisors. When you take an OBG, you can notice that there is a supernumerary blocking and preventing the central incisor from eruption. So that's called impacted. It's impeded from the eruption. So we call this as a 5i, which goes on the top priority of treatment. If you look at this central incisor as well, it's prevented from eruption because of the dilaceration of this central incisors. That goes again to the 5i of the top of the list of our patients. That's a huge priority of treatment. Now, we said as well, if the tooth has not erupted because of the lack space, that's considered impaction as well. And we know that the last tooth to erupt in the upper is the canine. So usually, if we have a space problem, the tooth that most likely to be affected in the upper arch is the canine, while in the lower arch, it's the premolar, the second premolar. So let's assume here that this is in the upper arch. According to the IOTN, if the gap between the two teeth is less than 4 millimeters, the tooth is considered impacted because there's no enough space for this tooth to erupt, whether it's a canine or a premolar. So if we don't have enough space for the tooth to erupt, and that cutoff point is 4 millimeters, if it's less than 4 millimeters, the tooth is considered impacted and it goes to a 5i. According to the IOTN, they said if the space from the mesial of the 6 to the distal of the 2 is less than 18 millimeters in the upper and less than 17 millimeters in the lower, then the canine is considered impacted. So how did these measurements come from? Now, if you measure the distance between the mesial of the 6 to the distal of the 2, that means we have the 3, 4, and 5. So in the upper arch, the mesodistal width of the 5 and the 4, usually 7 millimeters, and the mesodistal width of the canine, usually 8 millimeters. So 7 plus 8, that's total 22 millimeters. So you need a 22 millimeter to accommodate the 3, 4, and 5 in the upper. Take 4 millimeters from that, which is, we said that the space should be more than 4 available for the tooth to erupt, so that's 18. So if the space between the 6 and the lateral incisor is less than 18, which means that one of the teeth that erupt the last, which could probably end up on the canine, will have less than 4 millimeters to erupt, which means that this tooth will be impacted and we will classify it as a 5i. We're still in the missing. We here talk about the hypodontia. So when you have a missing tooth, and that would be a hypodontia, if we have one tooth missing in each quadrant, okay, that's called 4H. Okay, so not necessarily in each quadrant. I mean, so in per quadrant, we have only one tooth missing, not more than one tooth missing in a quadrant. That's go for 4H. Well, if we have more than one tooth missing in a quadrant, that's a 5H. All right. So for example, here, as in the top one is a 5H, while this one in the bottom is 4H. Having said that, it's only considered if we need to do a treatment for that, either to open a space or to close the space. So sometimes you have a missing lateral, but the canine is in contact with the central incisor, and the treatment plan is just to reshape this canine, then that does not count in the IOTN. While if you need to open a space or close a space, then this is counted in the IOTN. So as you can see here, we have more than one tooth missing in a quadrant. So here, that's a 5H. That's a 5H of the dental health component. So that's now we finished by the missing. So if you looked at the malocclusion, there is nothing missing, no impaction. Then we go to the second important one in the list, which is the overjet. So we need to use the ruler again to measure the overjet, and here we're going to zoom in into this area which represent the positive overjet. Remember again that these two belong to the negative overjet part. So here there's a 2 again because it's kind of misleading. So here are the overjet ruler. the distance from here to here on this ruler is 0 to 3.5. Like if you use, it is a ruler. So if you use it on the patient's mouth, on the teeth, or on the study model, this distance will be 3.5 millimeter. So if it's recorded between 0 to 3.5, the overjet is in this area, that means it's 0. There's nothing to record. That's 0. Because this is normal. Well, if the overjet is between 3.5 into 6 millimeter, which is this area, and the lips are competent, and that's why the letter C stands for, it's recorded 2A. A stands for the overjet. While if the patient has an overjet between 3.5 millimeter and a 6 millimeter, or equal to the 6 millimeter, and the lips are incompetent, and that's why the letter I stands for, it goes as a 3A. While if the overjet is between 6 millimeter and 9 millimeter, regardless of the competent or incompetent lips, that's go to a 4A. While if it is more than 9 millimeter, that's go in the top of the score with a 5A. So when you measure the overjet, you need to hold your ruler radial to the line of the arch and measure the most prominent point of the most prominent upper incisors in the way similar to this one. So for example, here, if you have this, you see that central, lateral, all of them are different, and this lateral, you measure the biggest one, the biggest overjet that you got. The practical method is to hold the ruler parallel to the occlusal plane, and you look down to measure the amount of the overjet. And as you can see, you can use the ruler, the IOTN, as you can see here, the central incisors in the 4 area, so that means it's a 4A malocclusion. Now, if the incisal edge falls in a line between two categories, you score the lower one. You go to the lower one, not the upper one. So for example, if the incisal edge you see is touching the 5, touching the 4, you go and re-record the 4. That's 4A. Now the reversed overjet, here's our 2 again, that's the area where the 2 belong. The reversed overjet, if you measure it, and the reverse overjet between 0 to 1, as you can see this area here, that goes into grade 2B. If the area is between here and here, that represent -1 into -1 is 3.5. If there is a muscular problem or eating problem or speech problem, that's go to a 4M. Or if there's no problem, that's go to a 3. If the overjet is more than -3.5 millimeter, and there is a muscular issues and speech problem issue or eating problem, then that goes for a 5M. Whereas there is no muscular or speech problem, that goes to a 4B. Remember something, in order to record the negative overjet, you must have a 4 incisors in a negative overjet or in a crossbite. 3 of them, that will take you to a crossbite, which the next step in the evaluation. But 4 of them, that's a reversed overjet. So here we go now to the next step, which is the crossbite. And as we mentioned, the crossbite is called the crossbite when 1, 2, or 3, but not all the incisors are in a lingual crossbite. So if 4 of them are in a crossbite, that's negative overjet. But if up to 3, that's a crossbite. So then the way to measure it is to see the amount of the displacement between the centric relation and the centric occlusion. If the displacement is less than 1 millimeter, that's 2C. If it's 1 to 2, that's 3C. If it is more than 2 millimeter, that's a 4C. And if it's associated with a lingually crossbite, then this is 4I of treatment. Remember that crossbite without displacement not necessarily require treatment. And that's why in the IOTN, when you have a crossbite, you record the amount of the displacement. If you don't have a displacement, you don't record that crossbite. You need the displacement to record the crossbite, because as you can see here, if you don't have displacement, that's considered like a normal occlusion. So how to record it? You put the patient in the centric relation, and then you ask him to achieve the maximum intercuspation, and you see how much displacement took place. So for example, if you look at the top photograph, you can see that just at the centric relation, just at the premature contact before the full maximum intercuspation, we have a midline shift of the lower arch going to the left by around 3 millimeter. The patient is biting cusp to cusp. When he's fully closure, the midline is almost coincident, which means that the mandible has shifted or displaced in this direction by 3 millimeter. So the displacement of 3 millimeter, that goes into a category 4C. If this patient has no displacement, he does not score for the crossbite. Then we go to the displacement of the contact point, which is basically crowding. So just remember something, that the IOTN use a method similar to the little irregularity index. They don't measure the overlapping technique. They measure what we call it the displacement of the contact point, and this ruler is used for that. So if the displacement of the contact point between 1 to 2, that's 2D, 2 to 4, that's 3D, and more than 4 is 4D. So how is that working? You get the ruler, and this is here the area for the displacement of the contact point and the overbite. And as you can see here, we have 1, 2, 3, and 4. So you need to measure the distance between two contact points, and you record the biggest distance. So for example here, that's 3, and that's go into a 3D. So that's how the IOTN works. And you take the most severe one is recorded. You don't add this up. So if you have 2 teeth, one of them is 4D, one of them is 3D, then the score is 4D. So you record the most severe one. Now, this is kind of considered as disadvantage. Any vertical displacement is not recorded. You record only the anteroposterior one in one plane. You don't record the vertical one. And the displacement between the permanent and the primary teeth, for example, if a patient has an E, is still there, it's not counted. We only measure between permanent teeth. And this is kind of one of the weaknesses of the IOTN, because if you look at this patient here, aesthetically he looks fine. The lateral incisors are erupted palatally. But the dental health component gives him a high score, gives him a 4D, high need for treatment. I know that we can treat this patient in open space or whatever, but the other option is just simply to extract these laterals, and that's why the aesthetic component for this patient is low, is only 2. So this is kind of one of the problems of the IOTN. We're going to come back to that later as well. So the last one to consider when the MOCD sequence go, you have to keep that in mind. MOCD, the O stands for the overbite. So how are we going to assess the open bite and the deep bite? Again, the ruler that measures the contact point displacement is the same one used for the open bite. If the measurement is between 1 and 2 millimeter, that's 2E. If it's between 2 and 4 millimeter, that's 3E. If it's more than 4, it's 4E. And you record the biggest and the largest open bite that you have. And when it's come to deep overbite, we consider how deep is the bite, whether it's complete or not, and whether it's associated with the trauma or not. So if the overbite is increased and it's more than 3.5, but it's not complete and it's not associated with any trauma, that's 2F. If the overbite is complete and it's touching the palate, when I say complete, it's mean touching the palate, that's 3F, but without causing any trauma. But if it's complete and causing trauma, that means it's a 4F. So for example, here you can see that the lower incisors are causing ulceration and impingement of the palatal mucosa. That's a traumatic overbite that go up into a 4-5. So now we finished the MOCD, missing, overjet, crossbite, displacement of contact point, and overbite. Is that all the malocclusion? No. We have some additions to the IOTN, and that's the mention in the ruler. So the first one is 5S. It represents the submerging of the primary teeth. So if you have a submerged tooth that only 2 cusps are obvious, only the cusps are seen, and the neighboring teeth are tipped, we call that 5S. If the tooth is tipped against, erupted, but it's tipped against tooth to erupt, like this 6 here, tipped against the 5 or erupted against the 5, that goes to a 4T. We have a supernumerary tooth, but this supernumerary tooth erupted to the oral cavity and requires treatment, that goes into 4X of a treatment. However, a slight discrepancy in the buccal segment, as you can see here, goes to a 2G, which means that it doesn't need treatment. And here is that section from the ruler that describes the cleft lip and palate. It goes 4, 5, and if we have hypodontia or impacted teeth. This is a summary of the letters that is used: A for overjet, B for reverse overbite, C crossbite, D displacement of contact point. It's nice to memorize this one. It will help you a lot when you classify the IOTN. So by this now, we finished the dental health component and we're going to go to the aesthetic component. So how does the aesthetic component work? You simply look at these photos and then you look at the patient's teeth and you ask the patient to do the same. And then you do the rating of the overall attractiveness of the patient and not similarity. Meaning, so for example, if you look here at the number 9, the patient has a huge overjet, teeth are aligned, but they don't look nice. And the patient could be teased and bullying the stool because of this huge amount of overjet. So you don't consider this teeth as an attractive one. And you get a patient with, for example, severely rotated canine, that's crowding, not an overjet, but you consider that on a scale of attractiveness, that will be on the 9 as the least, or the one before the least attractive one. So you give him 9 score. So scoring the aesthetic component is not about similarity, because as you can see here, none of these ones are class 3. So does that mean that aesthetic component is not important for class 3? No, it's about the attractiveness. And actually, not having a class 3 patient in the aesthetic component is one of the disadvantages of the aesthetic component, but still we use it. They found that there is a high level of agreement between the professionals and the patient when it's come to the assessment. What does that mean? So if you go to the patient, I say, okay, I want you to assess yourself. Where are you on this scale? So it will be 7. And the clinician answer will be 7 as well. So that's what we mean by high level of agreement. Now, some suggest to use the aesthetic component but in a monochromic fashion. What does that mean? You take the same paragraph that we have before, or the same photograph, but instead of using color, use it without colors, and then you look at the study model and compare them to look at the similarities. The advantage for this is not to be affected by the oral hygiene. If the patient has poor oral hygiene or multiple caries, you think that he has a more severe malocclusion. So according now, we finished the dental health component and the aesthetic component, so who gets the treatment? According to the NHS, if the patient score a dental health component of 3 or more, or the aesthetic component of 6 or more, then he is entitled for treatment. If he's less than that, he's not entitled for treatment. But is the IOTN the perfect index? Is there any problems with the IOTN? The answer is yes. If you look at this malocclusion, you can see that the teeth are nice and well aligned. Okay, there is a little bit of rotation of the lateral incisors. So if you look at that and you say, okay, he will be recorded as a 4D because of the contact point displacement. And that put him in a high priority of treatment. He's a 4D. However, if you look at the photograph, no, this patient is not in a high need of treatment. Actually, he might live his life nicely without doing any orthodontic treatment. And this is the validity of the IOTN. Now, we can say that the IOTN is reproducible, but we can't say it's valid. All right? So, because it can score a patiently high when the need for treatment is low, and that's why we talk about the validity. And minor irregularities may not score high enough to place the patient on the treatment. So it's kind of the opposite. So if you can see this patient, he needs treatment. He has a crowding. But like if you go to the contact point displacement and try to measure it, you find it, for example, the maximum one is a 3 millimeter. So that gives him a 3D. Still not high enough. It is indicated for treatment, but a lot of patients will go for treatment before him because they score 4D and 5D. So patients with irregularity, they don't get high enough score so that they can get the treatment. And one of the most important limitation of the IOTN, as I think about it as well, that we can't do summation of the malocclusion. So for example, you have a patient with crowding and deep overbite and increased overjet. It's much more difficult than patient with well-aligned teeth, normal overbite, and increased overjet. But the IOTN score for both groups is the same, because the highest hierarchy go for the overjet. Once you evaluate the overjet, then that's it, done. And I can understand, because this is a need for treatment. This is not a complexity of treatment, that there's a difference. If you're studying the complexity of the treatment or the progress of the treatment, then yeah, you need to get adding different type of the malocclusion. And also, although IOTN cover a wide range of malocclusion, is there some patients they are not covered? For example, patients with periodontitis and periodontal problem, it's not covered in the IOTN. Patients who need a restoration, but before this restoration, they need an orthodontic treatment to align the teeth for the restoration to be done, and it's not there as well. Trauma, teeth that has suffered from trauma and they need an orthodontic treatment after that, and also it's not mentioned in the IOTN. So we continue in the limitation. The question is, does it measure the need for orthodontic treatment? Validity, the answer is no. And we saw that it's not valid. Sometimes, not always, but sometimes it's not valid. And don't forget something, that IOTN prioritizes treatment depending on the need. And the need for treatment is dependent on our understanding at the time of the development of the IOTN on what is necessary for treatment and what is not. Because we know now that there is no evidence linking malocclusion with, for example, temporomandibular joint dysfunction. So our understanding about the need is now. So maybe later in the future, our understanding will change and the IOTN has to change, or at least to develop. And this is one of the most important limitations, I think, is that it has little allowance is made for the facial aesthetic and psychological impact of the malocclusion. So for example, there is nothing mentioned about the gummy smile. So a lot of patients, they might seek treatment just because of the gummy smile. It does nothing about the psychology of the patient. Now some patients, they have just simple spacing and antiasthma, and he get bullied and teased in school. And that goes into the psychological impact of this malocclusion that is not considered in the IOTN. And that's another huge limitation with the IOTN. So how the IOTN is doing with the studies and reproducibility. Brock and Shaw, they did the reproducibility study and they found that the dental health component is fairly reproducible with 86.4%. When the rest of people who disagree about the IOTN, the disagreement was in a descending order: crowding, increased overjet, crossbite, and overbite. So what about the aesthetic component? They found that there is a huge agreement, or high agreement, between the score that we got by the patients, parents, and the orthodontist. So that was all for index needed for assessment of a need of a treatment, which is basically the IOTN. And all the people who are going to sit the MOCD exam, they need to know the IOTN score, because simply this is the score or the index that is used in the UK. So then you need to monitor the orthodontic treatment. What does that mean? So for example, you get a patient who are treated, and then in the mid-treatment or the end of the treatment, you need to prove that you have improved the malocclusion of this patient. You need a numerical thing to measure the improvement that happened due to the treatment. And here is come the BEER assessment rating, the bar index. It's given a cumulative score, indicated the extent of deviation from normal function, assessed from the dental study model. It used the pre-treatment, post-treatment model, and you give them a percentage of the improvement. So you say, okay, this is your score before the treatment, this is your score after the treatment, then you divide them, and that's the percentage of the improvement of the treatment. There is 11 component for the bar index: the upper anterior segment, lower anterior segment, upper buccal segment, upper right segment, upper left segment, lower right segment, lower left segment. And then buccal occlusion on the right, buccal occlusion on the left, overjet, overbite, and center line shift. So we are talking now about the upper labial segment, lower labial segment, upper buccal segment in the left and right, and lower in the left and right, without any occlusion, just looking at the segment. So the labial segment is from mesial of the 3 to the mesial of 3, while the posterior segment is the mesial of the 6 to the mesial of the 3. Take into consideration that the molars are not included. So you measure the contact point displacement as we did in the IOTN. So if the displacement is 2 millimeter, that's a bar score of 2. And if there is an impacted tooth, that's a bar score of 5. And then you multiply this by what we call it here in the bar index, the weight. So here is the weight of this segment is 1. So for example, if it's scored 3, that's score 3 multiplied by 1, that's 3. You don't double it or anything. So what you look at is the spacing, crowding, and impaction at this stage. If the tooth is impacted, that goes immediately into 5-bar score. So, not like IOTN, you consider spacing. Alright, well in the IOTN we consider only displacement of the contact point. So here you look at the displacement of the contact point, spacing, and the last one is impaction. Again, as we mentioned before, if the space available for the tooth to erupt is less than 4 millimeter, that's mean an impaction. And it's the same here with the bar index. So if you look here at the distance between the mesial of the 6 and the lateral, as you can see here, this space is just enough for 2 teeth. So if we measure this distance from here to here, it should be 22 to accommodate 7 for premolar, 7 for premolar, and 8 for canine. But if it's less than 18, it means that 7 for the premolar, 7 for the other premolar, that's 14. And 14 minus 18, the space that is available, that's only 4 millimeter available for the canine to erupt. And we said before that if the space available for the unerupted tooth is less than 4, that tooth is impacted. And it's here the same again in the bar index. So I will say the bar index will consider spacing as well. So you need to measure the amount of spacing. So if you go here, you measure this one, it's a huge amount of space. But this space is not counted unless you are planning to do space closure using orthodontic treatment to move the teeth to close the space. Or the plan is to open a space, but the space available for this tooth is 4 or less, and that you need to make this space bigger. Here it counts in the bar index. Then we go to the buccal segment. So we finished anterior segment, upper anterior segment, lower anterior segment, upper left buccal segment, lower left buccal segment, upper left buccal segment, right buccal segment, lower right buccal segment as well. So now we have the teeth into occlusion. We call it the buccal occlusion on the right, the buccal occlusion on the left, and it's considered from mesial of the 6 to the distal of the canine. And you assess it in a 3-dimension: vertical, anteroposterior, and transverse. So vertically, if there's lateral open bite or not. Anteroposterior, class 1, class 2, or class 3, half unit or full unit. And the last one is the transverse problem, whether there's a crossbite or not, crossbite tendency, and all of that. The weight for the buccal segment occlusion is 1. So for the overjet, for the contact, the anterior segment is 1, and for the buccal occlusion is 1 as well. Then you measure the overjet. So it's the same way we do it with the IOTN, but here is the score. So if the overjet is 3 millimeter, if the overjet is 7 to 9 millimeter, that's score of the IOTN of 3. What you need to know about the IOTN that if you have a positive and negative overjet, you add them together. So meaning, if you have an overjet here of 5 millimeter, that will score as a 5 millimeter, that score as a 2 bar index. And here as well, you have a negative overjet, okay, of about in a crossbite, and that's will go into this category that we have a 1 single tooth in a crossbite. So that's mean 2. So 2 for the overjet, 2 for the crossbite or the reverse overjet, that's the score of 4. Alright, that's the difference in the scoring, because you are scoring the positive and the negative overjet and they don't cancel each other, you just add these numbers into each other. And the weight of the overjet is 6. So you multiply your results by 6. Which means that the overjet has a huge impact and huge effect on this kind of indexes. Then you go to the overbite. So we have the same thing. We have overbite and we have a deep overbite. So you can here see and you score it according to what is the malocclusion feature. And the score is multiplied by 2. So far we have anterior segment, it's score 1. We have the buccal segment scores 1. While the overbite scores 2, and the overjet the maximum with a 6. Then the last one you consider is the midline discrepancy. You need to assess the midline. So you look at the midline and you take the lower as a reference. If it is between 1/4 of the lower incisors, that goes up to a 1 into the bar score, while if it's more than half unit, that's go into 2. And don't forget that the weighting of the center line is multiplied by 4. So the most important feature of this malocclusion, according to the beer index, or the bar index, sorry, is the overjet, followed by the center line, because that scores 4, and the last one is anterior open bite or deep bite, that scores weight, 2. So how is the outcome measured? So we did evaluate pre-treatment and we did evaluate post-treatment. So they said there's 2 ways of doing that, or 3 ways. The first one is if you do that, you need to make sure that there's an improvement of 22 points. That's mean a good improvement. Or you divide them and you get, if you get 70%, more than 70% improvement, we can consider the standard as good in orthodontics. While if it's between 30 and 70, then the reduction represents an improved outcome. While if it's less than 30, then there is no or little improvement and the outcome is not acceptable. So then recently a new index came up trying to mix the bar and the IOTN. It's called the ICON. Basically index of complexity and orthodontic needs. So basically it does 2 things. It gives you an information how difficult is it to treat the patient, and it gives you about the need for orthodontic treatment using the IOTN. So it can merge the bar and the IOTN. Last but not least, little irregularity index, and this is something that we all need to know. Well, Little is a man who worked a lot on the retention, and he followed his sample over 20 years. So then he produced something that he need to use to measure the amount of irregularity resulted from relapse. So he measured what we call it contact point displacement, where this contact point is from this contact point. It's similar to the one we use it in the IOTN. So if there's a perfect aligning, 0, minimal irregularity 1 to 3, moderate 4 to 6, and the maximum is 10. Little improvement, he introduced his an index. He said that if the index is more than 3.5, then the treatment is not acceptable and should be retreatment for this patient. The treatment are not acceptable due to the relapse that happened. That was it. Thank you very much for your listening.